Hello everyone, thanks for joining me. My name is Maxwell. I am a general physician from Hope Exchange Medical Center in Ghana. And in this presentation, we're going to be looking at demyelinating disease of the central nervous system, specifically multiple sclerosis. Disclosures: I've got nothing to disclose. So multiple sclerosis is a chronic inflammatory disease of the central nervous system. And what happens here is that the immune cells of the human body starts to eat away the myelinated axons in the central nervous system. It's very common in young women between the ages of 20 to 50 especially. And the cause is really not known. It's immune mediated and it's often influenced by some genetic and environmental factors. So multiple sclerosis is very common in countries in the northern hemispheres, like in Canada, the United States, the Scandinavian countries. Down here in Ghana, it's not very common. Well, we still see one or two cases here and there. Pathologically, multiple sclerosis is characterized by what we call focal plaques, and these are areas of demyelination and inflammation, especially around postcapillary venues. So like we see in this slide, these are red blood cells, and they are surrounded by immune cells, lymphocytes and macrophages. Inflammation basically going on here. So now let's look at some of the imaging findings that we are likely to see in multiple sclerosis. It's important to know that demyelination in multiple sclerosis likes to occur in specific areas of the brain, like the paraventricular area, the corpus callosum, the cortex. There's something we call subcortical lesion and juxtacortical lesion. We're going to be looking at images of these soon. Also, the infratemporal region of the brain and in the spinal cord. The optic nerve is also commonly affected in multiple sclerosis, and it's a common presenting sign. Active lesions tend to enhance on post-contrast imaging in multiple sclerosis. So here is an example of a paraventricular lesion. So we see multiple white matter demyelination around the lateral ventricles of the brain. And also, specific for multiple sclerosis, paraventricular lesions usually touch the tips of the lateral ventricles, as we see here. So that's an example of a paraventricular lesion in multiple sclerosis. We also see here in the next image multiple lesions in the corpus callosum, and that's an example of a callosal lesion. Here's an example of a cortical lesion. The first image is a juxtacortical lesion and the second image is a subcortical lesion. The main difference between a juxtacortical lesion and a subcortical lesion is that in a juxtacortical lesion, the lesion or area of demyelination is directly attached to the cortex, as we see in the first image. Whereas in the second image, the subcortical lesion, there is a little space between the area of demyelination and the cortex. Here's an example of a spinal lesion in multiple sclerosis. So we see here an enhancing lesion at the second and third vertebrae. Usually for multiple sclerosis, spinal lesions are short segmented. And right next to it is an infratemporal lesion. We see multiple lesions in the cerebellum, and this is also very typical for multiple sclerosis. So what should a radiologist look out for in an MS exam? If it's a baseline exam or the very first exam, you're looking at signs of demyelination in the brain. T1 lesions are hypo-intense. T2 and FLAIR lesions are hyper-intense, and post-contrast lesions are enhancing or bright. You're looking at the location of the lesion and the number of lesions there. You're also looking to see if there is any brain atrophy or structural changes in the brain. If there are any enhancing lesions, it means that the patient should be put on steroids to decrease the inflammation going on in the brain. For follow-up scans, you're looking at new lesions. Are there any new lesions? If a patient is on disease-modifying therapy and there are new lesions, it means that some adjustments should be made to the drugs or the patient should be put on new drugs. You're looking to see if there are any dark lesions. Dark lesions represent permanent brain tissue damage, and it's often seen at the advanced stage of the disease. How do we diagnose multiple sclerosis? The McDonald criteria is a widely accepted criteria used to diagnose multiple sclerosis. It is actually the clinical, the radiographic, as well as the laboratory criteria used to diagnose multiple sclerosis. And the McDonald criteria deals with two concepts. The first is dissemination in space. In dissemination in space, we are looking to see if there are more than one T2 lesions in at least 2 out of the common areas where demyelination in multiple sclerosis usually occur. That is the paraventricular area, the cortex, the infratemporal region, the corpus callosum, or the spinal cord. If there are more than one T2 lesions in at least 2 out of these areas, this satisfies the concept of dissemination in space. The second concept of the McDonald criteria is called dissemination in time. Dissemination in time asks the question, is there a new T2 lesion on a follow-up MRI compared to a baseline scan? The time interval here is not important. So if a patient goes for a follow-up exam and there is a detection of a new T2 lesion compared to the baseline exam, it fulfills the concept of dissemination in time. Also, the presence of enhancing and non-enhancing lesion on an MRI fulfills the concept of dissemination in time. It's important to know that oligoclonal bands in CSF can replace dissemination in time. So let's look at 1 or 2 cases and try to diagnose them with the principles we just learned. In the first case, we have a 32-year-old woman present with tingling and weakness in the extremities. So we have 3 images down here, 2 FLAIR images, axial and sagittal, and 1 T2 spine. In the first image, we see multiple hyperintensive lesions around the lateral ventricles of the brain, the second, the third, the fourth, and the fifth. This is very typical for a paraventricular lesion. And in the second image, at the 4th and 5th vertebrae, we see a slightly hyperintense lesion in the spinal cord. There it is. And also, the final sagittal FLAIR image, we see multiple lesions in the corpus callosum. So in this case, we have multiple paraventricular lesions, we have a spine lesion, and we have multiple lesions in the corpus callosum. And this fulfills the concept of dissemination in space. Remember that in dissemination in space, we're looking at 1 or more T2 lesions in at least 2 out of the 5 CNS areas where demyelination usually occurs in multiple sclerosis. Alright, so now let's take a look at our next case. We have a 40-year-old female present with weakness in the upper and lower extremities, usually worst in the morning. She's had previous episodes of difficulty reading. So we have here 2 T1 weighted images here, a baseline and a follow-up scans. We also do have a T2 sagittal spine. So when we take a look at the T1 images, we quickly see a lesion in the follow-up scan demonstrating low intensity. Here we see it compared to the baseline. And also when we take a look at the sagittal spine, we see a slightly hyperintense lesion at the 2nd and 3rd vertebrae. Now, we already know that the patient previously has had difficulty reading, so this probably should give us a suspicion what we could be dealing with. So, based on the history of the patient and the images we just looked at, we are able to conclude that the patient probably has multiple sclerosis. Looking at the baseline and the follow-up scan, this actually fulfills the criteria for dissemination in time. Remember that in dissemination in time, we are looking to see if there is a new lesion on the follow-up MRI when we compare it to a baseline scan, irrespective of the time interval. And that's what we are seeing here in this case. Now, let's look at some of the basic imaging updates for multiple sclerosis. The collaboration between the magnetic resonance imaging in multiple sclerosis group and the Consortium of Multiple Sclerosis Centers, together with the North American Imaging in Multiple Sclerosis, aims to provide guidance on how best to use MRI in the diagnosing and monitoring of patients with multiple sclerosis. Let's look at gadolinium usage. The new update is that the use of gadolinium in MRI for multiple sclerosis exam should be restricted to baseline scans only. That is, before beginning disease-modifying therapy. A new baseline MRI without gadolinium is recommended months after the onset of treatment, followed by annual brain MRI still without gadolinium while the patient is undergoing treatment. So it's important to know that the routine use of gadolinium-based contrast agents is not recommended for follow-up examinations. Gadolinium-based contrast agents is also contraindicated in pregnant patients. Spinal cord imaging for routine follow-up individuals is also optional. Now let's look at some differentials for multiple sclerosis. And the first is neuromyelitis optica. NMO and multiple sclerosis can be pretty challenging to differentiate, yet there are slight differences. So the first is that in NMO, the spine is more involved than the brain. As compared to multiple sclerosis, it involves more of the brain than the spine. Also, spine lesions in NMO are long segmented, whereas in multiple sclerosis, they are pretty short segmented. NMO also involves more of the central cord, as compared to multiple sclerosis, which is more peripheral. And aquaporin antibodies is the key take here for differentiating multiple sclerosis and neuromyelitis optica. Acute disseminated encephalomyelitis is another important differential for multiple sclerosis. This is common in children and young adults after a vaccination of viral infection. Unlike multiple sclerosis, it equally affects males and females and has no predilection for female. There are tumefactive regions in the supratentorial and infratentorial brain parenchyma, and the cortex and spine are less involved. Also, callus-receptor interface and thalamic lesions are not uncommon. The last important differential for multiple sclerosis is what we call myelin oligodendrocyte glycoprotein antibody-associated disease, aka anti-MOG. This is also associated with children and young adults. The most common clinical presentation here is bilateral optic neuritis and transverse myelitis. Cerebral involvement is variable, with about 50% of patients at the time of diagnosis without brain lesions. Involvement of the spine may have leptomeningeal enhancement, and anti-MOG is almost indistinguishable from ADEM. Important lab findings include CSF myelin basic protein and CSF phagocytosis. In summary, multiple sclerosis is an immune-mediated inflammatory disease of the central nervous system that leads to neurological impairment in young adults, particularly females. The McDonald criteria is used to diagnose multiple sclerosis, and it deals with the concept dissemination in time and dissemination in space. The use of gadolinium-based contrast agent is not routinely recommended in follow-up scans due to its toxic effect on the human body. Thank you very much.